guys, welcome to Pathology Discussion Forum, and today in this vlog I'll talk about hereditary spherocytosis. Now, in the peripheral blood we commonly get this type of RBC. This is one mature RBC which has presence of central pallor due to lack of hemoglobin in the center of this RBC. This is the normal structure of RBC that we usually get in the normal peripheral blood smear. But in case of hereditary spherocytosis, there is presence of spherocytes. Spherocytes are that red cells which is slightly smaller than the normal RBC, and there is absence of any central pallor, and it is densely hemoglobinized. So this is a normal RBC and this is a spherocyte. Now, how this spherocytosis is actually that occurs? Now, spherocytosis is a genetically determined hemolytic anemia, or it is one kind of hemolytic anemia. That means there is hemolysis. RBCs are broken down in pieces, and that results in various types of manifestations. Now, why these RBCs are broken in pieces? Now, to understand this, we have to look at the structure of the RBC membrane over here. Now, normal structure of RBC is like that. Here is the lipid bilayer throughout the membrane. That means I am talking about this membrane. So there is presence of lipid bilayer throughout the membrane, and at several places in this membrane there is presence of some proteins, some transmembrane proteins, and these proteins, they play vital role in different aspects. So there is one protein called as band 3 protein. It also acts as a anion channel. Now there is another important protein, that is ankyrin. Okay, and this ankyrin helps to attach band 3 protein with the spectrin. Spectrin is the major cytoskeletal protein. So this spectrin, which has this helical structure, it is attached with the RBC membrane with the help of ankyrin and band 3. Also there is another attachment. There is presence of glycophorin C, that is a transmembrane protein, and it is attached with the spectrin with the help of protein 4.1. So these two are the anchorage point of the cytoskeleton with the RBC membrane, and this anchoring, it helps to maintain the biconcave shape of RBC. The biconcave shape means there is less diameter in the center than the periphery, and it enables an RBC to have a high surface to volume ratio. That means there is more surface area comparing to the volume of the RBC. Also, this lipid bilayer, it helps to maintain a high level of elasticity and deformability to the RBCs, and this high level of elasticity and deformability of the RBCs, they actually helps them to pass through small or smaller blood vessels. As we know, the normal diameter of an RBC is about 7 to 8 micrometer. But in some places, especially in the spleen, there are splenic cords, and some places these cords have very less diameter. That means it has a 2 to 3 micrometer diameter, and this normal RBCs has to pass through those smaller cords. That is why they are much more elastic and they are much more deformable, so they can easily pass through those splenic cords. Now, in case of hereditary spherocytosis, there is deficiency or defective production of this type of proteins. The most common defect in the formation is related to this ankyrin protein. This is the most common defect in the red cell membrane in case of hereditary spherocytosis. But also the defect in band 3 protein or protein 4.1 or glycophorin and also these spectrin defects, they also can result in formation of hereditary spherocytosis. So in this picture we can see that there are two main anchoring points between the red cell membrane with the red cell cytoskeleton, and these two anchoring points are band 3 ankyrin spectrin association, another is glycoporin C, protein 4.1 and spectrin associations. And but in case of hereditary spherocytosis, these two anchoring points are defective due to defective production of this type of proteins. So there is a deformity in the membrane of red cells, and due to that there is loss of this biconcave shape of RBCs. Now what happens when these spherocytes, they usually pass through the spleen. Now normally a normal RBC that can easily pass through spleen or splenic cords, as because they are more elastic and they are more deformable, they can easily pass through the splenic cords. But when spherocyte enters into the splenic cords, they are easily trapped in the splenic cords and they stay there for a longer duration. And due to staying in the longer duration, they usually loses the glucose, and due to loss of glucose there is loss of ATP formation, as well as there is increased pH in the cytoplasm of RBCs, and all these factors, they leads to formation of surface blebs in the RBCs, and gradually these surface blebs, they are pinched off from the RBCs. So the surface area of the RBCs are decreased. In this smaller surface area, if an RBC has to maintain its shape, its biconcave shape, it is not possible. So the most common shape they usually take, that is a round shape. So a normal RBC that is having a biconcave shape, it is turned into a spherical structure, and there is loss of central pallor in this type of RBCs. So the surface area is gradually reduced, and there is presence of presence of hemoglobin within it without presence of any central pallor, and the total surface area is decreased. So this is how spherocytes are generated. After attaining that structure, then it can easily be passed through the splenic cords, and it can be present in the peripheral blood, and which we usually get in case of the hereditary spherocytosis when we examine the peripheral blood smear. Now again, when it enters the splenic cords, it may be trapped and it may be destroyed by the macrophages present in the reticuloendothelial system. So there is presence of hemolysis, and this is one type of hemolytic anemia, and this hemolysis that actually occurs due to defect in the red cell membrane. Now it has two types of inheritance. It may be autosomal dominant or autosomal recessive. In 75% of the cases it is autosomal dominant, and 25% of the cases it is autosomal recessive. But the interesting fact is that when it has an autosomal dominant pattern of inheritance, then the symptoms are less severe. Rather, in case of autosomal recessive inheritance, the symptoms are more severe. Now, what we usually find in the peripheral blood smear in case of hereditary spherocytosis. In peripheral blood smear, we find this kind of spherocytes. So, spherocytes are relatively smaller red cells with loss of biconcave shape of RBC, that is characterized by the dense hemoglobinization of the cytoplasm. That means there is absence of any central pallor, and these types of RBC, they are usually smaller than the normal RBC. So these are the spherocytes, and we usually find these types of RBC in the peripheral blood smear. But in case of the red cell indices, find an interesting finding in case of hereditary spherocytosis. The MCV or the mean corpuscular volume, that is normal to low, but the MCHC or mean corpuscular hemoglobin concentration, that is increased. So why there is such change? Due to loss of the red cell membranes in forms of vesicle, there is less amount of the surface. So the volume that usually decreases. That's why the MCV, that is either normal or low. But due to loss of these types of vesicles from the RBCs, there is loss of water as well as potassium from the RBC. And this loss of potassium and water, they usually leads to dehydration within the RBC. And this dehydration causes the increase in the MCHC. This entity is not common globally, but it is prevalent in the northern European areas, and the autosomal dominant inheritance is 75% cases, although the severity is much less. Now let's talk about the clinical features. Now there is presence of hemolytic anemia, that means there is presence of destructions of the RBCs, and this type of destruction, it is usually extravascular. That means the RBCs are destroyed mainly in the reticuloendothelial system, and principally it occurs in the spleen. So there is presence of extravascular hemolysis in case of hereditary spherocytosis. So due to hemolysis, there is more production of the bilirubins, and this bilirubin leads to presence of intermittent jaundice in those patients. And due to destruction of this hemoglobin or RBC, there is presence of mild to moderate amount of anemia. So normally the severity is not much, it is mild to moderate in severity. Due to extravascular, due to increased amount of lysis and due to extravascular hemolysis, there is presence of splenomegaly in those patients. And as because there is formation of more amount of the bilirubin, so there is more formation of the pigmented bile stone or pigmented gallstones, and this will cause presence of gallstones in these patients, and they usually present at an early age. So if any child presents with gallstone at an early age, we can suspect hereditary spherocytosis if there is any abnormality regarding his peripheral blood findings. Now I'll talk about the exacerbations of anemia. So there is a fluctuation in the amount of anemia in those patients. Now these exacerbations, they usually occur in certain scenarios, like aplastic crisis, that is caused by parvo B19 infection. As we know that parvo B19, it is one type of virus that it commonly involves the erythroblasts, and it suppresses the process of erythropoiesis. So there is ongoing destruction of the RBCs, and the process of erythropoiesis, that is also suppressed by this virus. So there is aplastic crisis, that means the amount of anemia that is suddenly aggravated. Now normally there is increased amount of erythropoiesis to maintain the amount of hemoglobin in the blood. So if there is less supply of the vitamin B12 or folic acid, there will be development of the megaloblastic crisis. It will be characterized by presence of megaloblasts in the bone marrow, and there will be presence of megaloblastic maturation in the bone marrow. And if there is infection, if there is due to any infection, there is sudden increase in the amount of hemolysis, it will lead to hemolytic crisis. Now coming to the bone marrow examination findings. Bone marrow examination will reveal presence of erythroid hyperplasia, and there may be presence of megaloblastic maturation if there is deficiency in the supply of vitamin B12 or folic acid. Now coming to the most interesting part of this discussion, that is osmotic fragility test. Now what is osmotic fragility test? Osmotic fragility test, it is very important test to screen this condition, that means hereditary spherocytosis. It is one type of screening test. This is not a confirmatory test for hereditary spherocytosis. What is done here? We take several test tubes, and in those test tubes we take various concentrations of saline. That means there is presence of saline in the decreasing orders. The first test tube, there is presence of 0.7% saline solution. In the next tube there is 0.6%. Then in the third tube there is 0.5%, and in the fourth tube there is 0.4% saline solution. So here we take several tubes with decreasing concentration of the saline solution in them, and we add the RBCs into these test tubes. Normally what we usually get over here, that in normal patients, in normal persons, the hemolysis that usually begins at 0.5% concentration. So in the normal scenario, if we keep adding the normal RBCs to these tubes, the hemolysis will start at 0.5% of the solution, and it will gradually increase if we decrease the concentration of the solution. So there is presence of the first appearance of the hemolysis, that is at 0.5% saline solution. But in case of hereditary spherocytosis, as because these cells are smaller and they are densely packed with hemoglobin, and there is also less amount of surface area, so these cells are less elastic, as well as these cells have less deformability. So when these cells are exposed to a osmotic stress, then they easily lyses. That means normally the cells lies at 0.5% solution, but in case of hereditary spherocytosis it lyses at a higher concentration. That means in case of hereditary spherocytosis, the hemolysis that begins earlier at the concentration of 0.6%. So this is osmotic fragility test, and this test is used as a screening test for hereditary spherocytosis, and this is not a confirmatory test. Now why this is not a confirmatory test? Because this test has several limitations. The first limitation, that is, it is non-specific. This test may be positive when the blood contains spherocytes. These spherocytes are present in hereditary spherocytosis, as well as these spherocytes can be present in various other conditions like autoimmune hemolytic anemia, or it can be present in burn patients. So the positive test doesn't mean hereditary spherocytosis. It can be present in burns or autoimmune hemolytic anemia. So it is non-specific. Now the mild cases of hereditary spherocytosis. The mild cases, as because there is less number of spherocytes in the peripheral blood, so there is less amount of hemolysis, and sometimes it cannot be visualized at all. So it is negative in case of mild hereditary spherocytosis. And also the amount of hemolysis that decreases when these cells are resistant to hemolysis. When these cells become resistant to hemolysis, when there is presence of thalassemia or sickle cell disease, these cells become resistant. So if there is co-inheritance of these conditions along with hereditary spherocytosis, so there is chance of getting a false negative result. Now, how we can diagnose a case of hereditary spherocytosis? First, the osmotic fragility, it gives us an idea about the fragility of the red cells. It can indicate a case of hereditary spherocytosis, so it is used as a screening test. Now the more confirmatory tests are autohemolysis test. In autohemolysis test, what we usually do is we take a test tube and put some amount of blood in it and keep it in 37 degrees centigrade for 48 hours. In normal cases, when the RBCs are normal, there is less than 4% hemolysis. But in case of hereditary spherocytosis, the amount of hemolysis is much more. Now the next test, that is acidified glycerol lysis time. Here the acidified glycerol is added to the RBC and the time is measured to get a 50% lysis of the red cells. Now the Eocene 5 melamide binding test. Here this dye is applied on the RBCs and this dye, it usually favors to bind with the band 3 protein, and after binding with the band 3 protein, now the red cells are now analyzed with flow cytometry, and the intensity of this dye is measured with the flow cytometry, and if there is defect in the band 3 protein or this association of proteins, so there will be much less amount of fluorescence that we get in case of hereditary spherocytosis. Now the more confirmatory test, that is Sds Phase Electrophoresis. Now by this method, what we do, we perform electrophoresis with the RBC membrane proteins, and if there is defect or deficiency in any of these proteins, so it will be easily detected by this electrophoresis technique. So these are the diagnostic tests that we can use to diagnose a case of hereditary spherocytosis. Regarding the treatment, most of the cases the hereditary spherocytosis has mild to moderate in severity, so there is less need for the blood transfusion. But in severe cases, we can transfuse blood, and in severe cases, sometimes this splenectomy is performed. The splenectomy is done to minimize the red cell destruction within the spleen. Okay, that's it for now. If you are new to this channel, then don't forget to subscribe to this channel, and also don't forget to follow our Facebook page. If you have any questions regarding this topic, then you can post your question in the comment section below. I will try to answer your question in the next vlog. Thank you.